Yeah, very good evening, doctors. We are on live and we are starting the session. So, I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. So, I welcome all the chief guests, guest of honors, speakers, and delegates for the today's session. And I would like to introduce the coordinators for today's session, Dr. Niharika ma'am and Dr. Priyanka Ricer. Can I have the CV of Niharika ma'am? Yeah. Dr. Niharika Malhotra ma'am. Madam is currently the consultant at Rainbow IVF, and Madam is the chairperson Foxy Young Talent Promotion Committee, Joint Secretary Foxy 2018, and Madam is the Assistant Editor Journal of IJHRRD. So Madam is affiliated with various societies like Aspire, Ashri, RCOG, and Madam has also received various awards to her service and credit. And Madam has also published many books and articles, chapters and editors, and coordinated for many newsletters. I welcome you, ma'am. Now I'd like to welcome Dr. Priyanka Ricer. Actually, sir needs no introduction here. Sir is currently the consultant infertility and gynec endoscopy, Nova IVF and Royce Clinic, Siliguri. Sir is the India representative, WTOG figure 2018-21, National Coordinator for Technology Committee, Foxy, and E-Zone Coordinator, Infertility and Endocrinology Committee, Foxy. And Sir has also published more than 60 articles in national and international journals and received various credits and awards to his service. So we welcome you, sir. I'm handing the session to you for further proceedings, sir. Thank you, sir.
Thank you so much, and a very good evening to everyone. I bring greetings from my city of Agra, the city of love. Today we are here on 19th March on a wonderful program on International Academic Exchange webinar by Suffolk, IAPM and Ian Donald. Understanding genetic factors and basics of genetics and genetic disorders is very important for promoting health and preventing diseases. Incorrect epigenetic marks can result in birth defects and childhood diseases. Epigenetics also regulates development and adaptation during life. Every year, 3 to 6% of infants are born with birth defects. Today, let us all join hands to promote the importance of genetics and prenatal screening. It's such a wonderful day. March 3rd was World Defects Day. March 21st is Down Syndrome Day. And March, the month, is actually celebrated as Trisomy Awareness Day. So with these thoughts in mind, I would like to welcome Dr. Rohana here, President Suffolk, for his welcome address. We are so grateful, Dr. Rohana, you could join us here today. So Dr. Rohana is Chairman, Nimes Wealth Care, Mother and Baby Hospital, Secretary General AOFOG, FIGO Chairman of Menstrual Disorder Committee, President of Suffolk, Vice President Suffolk, South Asian Federation of Menopause Society. We welcome you here, sir.
Thank you, Nerga, for that kind introduction. Actually, I am the past chair of the Menstrual Disorders Committee of FIGO. Right, so I would like to welcome everybody to this international webinar organized jointly by Suffolk, IAPM and Ian Donald School. I thank both IAPM and the Ian Donald School for joining with Suffolk in organizing this webinar. You will realize that this is the second in the series of webinars organized with international organizations by Professor Narendra Malhotra, who is our dynamic director of international affairs in Suffolk. Narendra, as you know, is able to get the assistance from everyone and organize these programs in no time. So we admire and appreciate all his work and thank him for the commitment in all the educational activities in Suffolk. So I would like to welcome Professor Asim Kurjak, the IAPM President and Director, Ian Donald School, Inter-University School of Medical Ultrasound, and Chairman, Dean of International Academy of Perinatology. We appreciate very much your assistance in Suffolk activities. Today's webinar is on preconception, epigenetics, and genetics. It's a very well chosen title, as we do not address these issues very much. As just now mentioned by Nerka, so this is a very important, plays a very important role in our practice, day-to-day practice now, and it is becoming very essential for all of us to be very knowledgeable in this area, which is not being discussed so much. And so this area is, as you know, is a very changing continuously and advancing. So I am sure this webinar, today's webinar, will be very helpful to everybody. So I am happy to welcome the three chairpersons of today's webinar, Dr. Prag, Dr. Deepak, and Dr. Anna. So we are fortunate that three eminent speakers, Dr. Manjeet Mehta, Professor Fedora, and Dr. Raju, who will enlighten us with very, very informative lectures. Furthermore, I see that there is a very interesting panel discussion on prenatal screening and diagnosis with the participation of very knowledgeable clinicians and teachers from our region and outside the region. So I thank Professors Firoza Begum from Bangladesh, Aris Antakalis from Greece, Professor Farooq Saman, our past president of SAFOG, who has been behind most of the programs and has been a great strength to us, and Professor Atula Kaluarachi from Sri Lanka, and Dr. Bhatta Namara from Thailand. I thank you for your participation and for your valuable input. I am happy that today's program is moderated by two very enthusiastic young members, Dr. Niharika Malhotra and Dr. Priyanka Ricer. I'm sure their approach and their dynamism will stimulate all of us and make this program very lively and interesting. And finally, we have Professor Yusuf, Secretary General SAFOG, who has been behind all our SAFOG programs. So I will also take this opportunity to welcome Professor Rubina Sohail, past president of SAFOG, who is also a very live wire in SAFOG, and joining with all our programs and giving assistance. So before concluding, I wish to say thank you to the Indian College of OBGYN for giving 2 credit points for those who participate. So as we have a very interesting long program ahead of us, I don't want to take any more time of yours. So I will hand back to the moderators to continue with the program. Thank you very much.
Thank you so much, Dr. Rahana. And I'm sure we're going to have a great program today. This is actually the need of the hour. We also are grateful that Dr. Asim Kurjak also joined hands for today's program, and he's unable to join us right now. But Dr. Asim is the director of Ian Donald Inter-University School of Medical Ultrasound and also the president of IAPM. We'll be grateful if he joins us later, and I'll invite him when he joins. I would now like to invite Dr. Naren Malhotra, Director, International Affairs of SAFOG, and also being the Managing Director of Global Rainbow Healthcare, Director of ART Rainbow IVF. He's the Director of Manyata CSE and also the Project Positive Rotary District, and he has been the past president of FOXY and ISAR. We welcome you, Dr. Naren Malhotra, and I would like you to give your address.
A very, very good evening to all of you, and a good morning to people who have joined from USA. We see that few people have joined from there. So I bring you greetings from the International Academy of Perinatal Medicine. The International Academy of Perinatal Medicine is a very, very closed and highly professional organization where you become members and fellows only by invitation on the amount of work which you do in fetal medicine. And 2 years back, I got the associate fellowship. This year, the conference was to be in Marrakesh, and we have once a year fellowship programs. The next year, it will be in Qatar, and after that in USA, and 2025 in India, in Agra. So do join us. We look forward to all of you applying with your good biodata on the work and fetal medicine so that we can take you in this academy. And it is a wonderful academy. And I'm thankful to Professor Kurjak, who's been my mentor. I know him since my postgraduate days when Jaideep first presented her paper on fetal anomalies in the Ahmedabad AICG conference in 1985, and she won the Best Paper Award. Professor Kurjak was the judge there, and that is where our association began. and he's taught us what is ultrasound and what is there. So welcome to this webinar, and I'm sure we're going to have a great time discussing genetics here. Thank you, Niharika and Priyanka.
Thank you so much, sir. And let's begin our program for today. And we have a very academic-oriented program today. We begin with our first session on pedigree charting. And for this, I would like to invite Dr. Parag Biniwala as our chairperson. And we are grateful to sir for also giving us 2 ICOG credit points here. I invite Dr. Parag, Senior Consultant OBGYN Pune, postgraduate teacher and unit head from Kamla Nehru Hospital, Vice President ICOG 2021-22, President Menopause Society of Pune, President-elect of Pune OBGYN Society. We welcome you here, sir, and I request you to please introduce our speaker.
Thank you, Niharika. Good evening, all. I bring greetings from ICOG, the Indian College of OBGYN. And at the outset, let me thank Team SAFOG, President Rohana and Dr. Narendra Malhotra in particular for having me here to join this wonderful academic program. The first speaker is Dr. Manjeet Mehta, who is a consultant medical geneticist from Mumbai. She has a doctorate in human genetics from Jaslok Hospital, Mumbai, and has done postdoctoral fellowships from Toronto and London. Currently, she's the Director, Medical Genetics and Clinical Genomics, MMTSL, Mumbai. She has been awarded by the President of ISAR as Champion of ISAR 2020. She is a Managing Committee member of National ISPAT, National ISAR, and she has chapters and research projects and publications to her credit. So may I request Dr. Manjeet to begin the deliberations, please.
Thank you, Dr. Parag, for those kind words. I'm grateful to SAFOG, IAPM, Ian Donald, especially Dr. Narendra Malhotra for giving me this opportunity to present myself at this August meeting. Starting off with a case scenario, a class of medical students was asked a very basic question. What is the single most important step in the treatment process? Like most of us, we would guess physical exam or some radio or imaging diagnostics. But no, actually it is patient history. And that is exactly where the role of pedigree charting comes in. So we all know that patient history is as important as their symptoms. And without history, our lives amount to nothing. So the topic of my presentation today is pedigree charting. Pedigree charting is a simple way of mapping a person's family, their history, their conditions. You start off with the proband who comes to the clinic, go one generation up, get their information about the parents, their siblings, spouse, children, and then you go to the paternal and maternal side, uncles and aunts, the cousins, the grandparents, and then if possible, and it would be good if we can go till the great grandparents of both the grandfather and grandmother, both sides. So typically a 4-generation pedigree chart will help us a lot into the insights of the conditions of that family. A very simple example to elucidate the importance of pedigree charting and taking history. We had a 33-year-old male who was referred to us with severe oligo, and he was referred for karyotyping and Y microdeletion, which are the typical tests which are done in such cases of infertility. While talking to the couple, we understood that the husband had no relevant family or medical history, but the wife, as well as other members of the family, had a history of neurofibromatosis and NF1. They had been already diagnosed. Now, neurofibromatosis, we know, is a group of genetic disorders that cause tumors to form on the tissues, and it is inherited in an autosomal dominant fashion. So when we drew a pedigree and we try to understand the number of cases in the family with the condition, you can see there are several family members. So as a matter of fact, the indication for which they came, the karyotyping as well as a Y microdeletion, those reports were normal. So they were coupled for, the couple was counseled for neurofibromatosis, informed of the condition, informed of the inheritance pattern, and then accordingly counseled. So what basically is pedigree charting? What is a pedigree chart? It's just simply a diagram that shows the inherited genetic traits for multiple generations in a family. It shows the occurrence and the appearance of, or the phenotypes of a particular gene or an organism and its ancestors from one generation to the next. So the reason for using these pedigree charts is to follow the path of dominant or recessive traits through the generations, and to determine that those which are affected by the characteristics, those who carry the genes, those who are unaffected, it can help us derive a risk for all the family members, like the parents, the siblings, the offspring of the proband who has initially come to us. It is a concise way of bringing together multiple paragraphs of explanatory writing into one single diagram, and pedigree symbols are universal across the globe. So even if the patient travels to another country, rest assured, the other obstetrician who they will be consulting, they will be able to read the pedigree chart that we have prepared here. So the origin of the word is from a French word known as pied de creux, which means crane's foot, because the typical lines and the split lines resemble the thin leg and the foot of crane. So pedigree, as I've said, is a family tree or a graphical representation. And these are the standard symbols which are used universally. Males are represented by squares, females are represented by circles, and horizontal lines join parents or sets of siblings, and the vertical lines indicate descent. So when we go from one generation to the next, they come in a different vertical line. And double line indicates consanguinity. If the shape, the square or the circle is colored, means the person is affected. If it is half colored or lightly shaded, it means he's a carrier of that particular condition. So a few terms which are used quite frequently. So phenotype or a clinical presentation is typically the physical appearance of a person and the fact or not if he is having a particular genetic condition. As against that is the genotype, which is a blueprint. So whereas a person would be having a genetic mutation in the genotype, he may not exhibit it in a phenotype, as you are aware in all the recessive conditions. Now, this entire genotype or the blueprint of ours is condensed into 46 chromosomes, which we are all very familiar with. They are made up of 22 pairs of autosomes and 1 pair of sex chromosomes. On these chromosomes are carried the 30,000, 27,000 genes which we have. So each chromosome has hundreds or thousands of genes. Each gene is present in 2 alleles. Typically they come from maternal and paternal origin respectively. And if both the alleles are the same, it's known as homozygous. If both of them are different, it's known as heterozygous. Or in an X-linked condition, it's also known as hemizygous. So genes could be inherited either in a dominant fashion, whereas even if one allele is affected, the phenotype is exhibited. In a recessive mode of inheritance, if one allele is affected, the person is a carrier but does not exhibit the genotype. And we have several other fashions of inheritance, like incomplete dominance, codominance. Then some of the genes have multiple alleles, and some of them are polygenic traits. And for certain characteristics, there are multiple genes. So the basic Mendelian inheritance and the 4 common types, autosomal dominant means that gene is present on one of the autosomes, and a person will exhibit clinical features even if only one allele is affected. Examples of this are neurofibromatosis, Huntington's disease, etc. Autosomal recessive, both the parents have to be carriers to have affected child, because the clinical features are observed only when both the alleles are mutated. And all the carrier screening panel covers the autosomal recessive conditions, beta thalassemia, sickle cell, cystic fibrosis, PKU. So all of them are inherited in a recessive fashion. X-linked inheritance has a classical mother to son transmission. So like we have heard of the fragile X or color blindness. And the hallmark of an X-linked inheritance is the absence of male to male transmission. And females are typically carriers and males are affected. Y-linked inheritance is not very common, and the classical example of this is the Y-linked male infertility, which is the deletion of genes on the Y chromosome, which are deleted in azoospermia. And there are some conditions which exhibit genetic heterogeneity. So an example of this is congenital hearing loss or hereditary deafness. They are inherited in various different manners, like autosomal dominant, autosomal recessive, X-linked inheritance. So we need to understand the inheritance pattern, which gene is affected, which other family members are affected, and then and only then we'll be able to counsel them and tell them about the recurrence risk of the condition. There are, of course, exceptions to Mendelian inheritance. There are imprinting disorders. There are triplet repeat disorders like Huntington's disease and some of the other ataxia conditions. There's gene environment interactions, there's epigenetics. So all of these factors are to be taken into consideration when we are deciding an inheritance pattern. So now coming to the applications in obstetric practice, we had an interesting couple wherein one parent was affected with retinitis pigmentosa, and this couple was directly advised donor gamete. Now, we all know that retinitis pigmentosa is it's a genetic disorder that involves the breakdown and the loss of the cells of the retina. And, there's a progressive loss of vision from the periphery. And in extreme cases, it goes into like a tunnel vision. So now the inheritance of this also could either be autosomal dominant, recessive, or even X-linked. So rather than jumping to conclusions and thinking that it's an autosomal dominant and you use a donor sperm or donor gamete, it's good to get the couple themselves tested. If it is a recessive condition, you can screen the other parent. And if it is dominant, then you could still do a prenatal or a pre-implantation testing. So this couple came with 2 children who had died of Duchenne muscular dystrophy, 2 males, one at 9 years, one at 14 years. They showed the classical Gover sign in the child, and again, Duchenne muscular dystrophy is progressive, loss of muscles, and the children have difficulty in sitting or getting up from a sitting position. So they were surprisingly told by the doctor that you cannot have a normal child, and the lady went in for a tubal ligation. And then after that, they presented in our clinic. So, we explained to them that this is an X-linked condition, and there is a chance of having a normal child. So after that, this lady got operated. She had a tubal reversal, and then she had 3 pregnancies. In fact, 2 pregnancies, we by ultrasound, we just checked the sex, and because it was a female, we continued the pregnancy. I mean, all this was done with permission from the local regulatory authorities. And then the third pregnancy after that, it was a male. So then we said that it'll either be a carrier, he'll be affect DMD. So they decided to terminate the pregnancy. So all this shows us the importance of drawing up a pedigree charting, understanding the genetic condition, understanding the inheritance pattern, and then accordingly counseling them and offering them appropriate treatment. So there was this 10-year-old child in his school camp, he had the routine test, and then his mother says that the father has been diagnosed with colon cancer, and the doctors are calling it familial adenomatous polyposis, and she's saying there is a test for it. Should I get my son tested? Now the questions that typically arise, what is FAP? What causes it? Who else in the family could get it? Is it X-linked? Is it autosomal? Who should be tested? How can we cope? So we all know that this is a colon cancer syndrome wherein polyps start developing anytime from 7 years onwards to 36 years. And then they could develop into colon cancer by the third or the fourth decade of life. It is most caused due to mutations in the APC gene, because 95% of the patients have an identifiable APC mutation, and the inheritance is in a dominant fashion. So you are able to accordingly give the respective risk to the siblings, the children of the affected person, and then draw up a pedigree chart. You see the percentage risk of each person, and then accordingly you can offer appropriate testing to the siblings. So these are the more common ways of inheritance of most of the conditions. Genomics has progressed a lot in the last decade, and if today a pregnant lady walks in, either having a positive dual or quad test, or belongs to a high-risk community, we all know there are several conditions which are high prevalence in certain communities, or if there's a sudden cardiac death or any of these conditions, we need to draw up a pedigree chart. We need to go into detailed family history of, if possible, up to 4 generations. After that, the testing can be done. There are several testing options which are available. I'm not touching upon that because it's beyond the scope of this talk. And we know that for a different condition testing, there's a different type of testing. I mean, karyotyping may not work for single gene disorders, and sequencing is required for multigenic conditions. So these are the advances that have happened in the genomic diagnostics in the recent past. Now, coming to the clinician's role as a genetic counselor, the primary physician is the first point of contact. He or she has an excellent rapport with the couple, with the patient, because the family listens to them. It is important first to identify the cases which are requiring evaluation by a geneticist or any subspecialty, reinforce the genetic counseling, evaluate stillborns. We need good records of examination, autopsy, and fetal tissue sampling. Why to take pedigree? We get a very good understanding of the inheritance pattern. Accordingly, we could tell them the recurrence risk, the prognosis of the condition, depending on which gene is affected. It helps in counseling for the couple. And then we could do the testing of asymptomatic family members who could be at risk. Genetic diseases, we all know they are constitutional, they are lifetime, they affect multiple organ systems and frequent hospital admissions. The turnaround time for the tests is also really very high. They are all high complexity tests, and you need extremely skilled staff to do the testing. So keeping all these factors in mind, it is important to, take care of it beforehand, appropriately counsel them. And we all know that today genetics has entered mainstream medicine. There's been an exponential rate of development in terms of understanding and the direct clinical application for several of these conditions. Today, we are able to diagnose a large number of rare conditions, all of them in a prenatal stage. I mean, there was a time when we were only doing aneuploidy testing. There was a time when we were doing only numerical abnormalities. We have gone from the chromosomal level to the single gene level to a single nucleotide level. We are able to identify the carriers for common disorders and offer guidance on planning the family. And even before the symptoms exist, we can identify it through the person's genotype. Today, there are several advanced, newer sensitive tests which are having an improved detection rate and a lower false positive rate. And a woman want an informed choice, you know. At the same time, the genetic clinics and labs welcome an inquiry and referral. So it is really very important to keep this in mind at all times. And if you're in doubt about any genetic test or if it is available or not, or what to do with this condition, just pick up the phone and ask. With the kind of rapid diagnosis advances that are happening as of today, if a test was not available 3 to 6 months back, for all you know, it could be available today or sometime in the future. So thank you very much. That's all.
Thank you, Dr. Manjeet. It was indeed a comprehensive presentation, and you've really simplified the pedigree charting for us clinicians, because whenever we are dealing with somebody who's, say, who has history of recurrent pregnancy loss or a previous anomalous baby, we are always in a soup. And I think this is a very, very systematic way of managing these patients. And whenever we refer any of the patient to the geneticist, this is the basic chart or basic thing that the geneticist talks about. And I think it is really vital, because it would certainly help the patient in improving the outcome in the future. Thank you very much. It was indeed a wonderful presentation. Niharika, do we have any questions? I can't see any in the chat box.
Not yet, sir. If you'll have, we'll ask whenever they come. So thank you, Parag sir, and thank you, Dr. Manjeet madam, for such a wonderful presentation. And pedigree charting is so important, and I think we all should know and actually start practicing it in our day-to-day clinic. And let's have our second session now. And for our second session, I would now invite, our second session is on the importance of ultrasound in screening for fetal genetic conditions. And for this, I would like to invite our chairperson, Dr. Deepak Bagre, sir. And we welcome you here, sir. And it's such a pleasure to have you. Dr. Deepak is an immediate past president of SOGOG. He is also hold many positions, especially the head of Department of MP Shah Medical College, Jamnagar, Scientific Committee Chairperson of Gujarat State of Gynecologists, President Jamnagar Gynec Society, President Jamnagar IMA, and also the member board of studies, Sostra University. And we are grateful to have him here. And I would request Deepak sir to welcome our speaker.
Well, thanks, Niharika, for the wonderful introduction, and thankful again to you for getting me into this wonderful webinar today. Thanks, Dr. Rohana, Dr. Narendra, Dr. Yusuf, for all the things. Okay. Thanks, Dr. Anna, or is it Anna Vikic? Dr. Anna Vikic, a beautiful scientist, I would say, from Croatia. Look at her education. She started way back in '96, where she finished her high school. Then she had a postgraduate degree of MSc at 2006. But still, she continued to study. I don't know how long. Until she got a PhD in 2009. That's really, if I work experience, superb. If you say started as a teaching assistant up to the lecturer. And if you see the key qualifications, I think she has got all the qualifications which are available in the world of genetics. All the skills, English, Croatian, many publications, and almost all memberships in the world of genetics. Welcome, Dr. Anna. And it would be really a pleasure to learn something from a scientist of how sonography is going to help in genetics. That is what we clinicians are really important. Thank you.
And I'm coming from Croatia. I'm clinical cytogeneticist, and I work in for cytogenetic laboratory in clinical hospital Sveti Duh. In our lab, we are performing prenatal and postnatal diagnostics, and we are doing classical cytogenetic analysis, but also and molecular methods. The topic of my lecture is the importance of ultrasound in prenatal diagnostics of genetic conditions or genetic diseases. When I said genetic diseases, I mean on disorders that are caused by mutation in a single gene. This means that today I will talk only about such conditions, and I won't talk about chromosomal changes such as aneuploidies or structural aberrations of chromosomes. For the detection of genetic diseases, we are using different methods. In prenatal diagnostics, classical cytogenetic analysis is still a gold standard, and it is the first method that we are performing. But when cytogenetic analysis is normal and when we get normal karyotype, then molecular methods are performed. For this purpose, we are using molecular cytogenetic methods, which are array Cgh and FISH method, or molecular genetic methods such as PCR or sequencing. At the beginning, I will tell you something about array-based comparative genomic hybridization, or array Cgh, which is a method that is usually performed first after classical cytogenetic analysis. Array Cgh is performed on fetal DNA samples. The analysis is performed in a way that test DNA and reference DNA are mixed together, and then they are put on chip slide, and these two samples of DNA are hybridized to a microarray chip in a competitive way. Microarray chip is constructed in a way that we have an oligonucleotide probes, which are about 20 nucleotide pairs long, and this probe, actually the DNA sample, hybridize to those probes. After that, analysis is performed in a way of DNA dosage recording. Depending on the chip construction, a different number of probes are present. And what is important, that these probes are covering the whole genome. And this is the main advantage of this method, that we are scanning actually the whole genome in one process. Depending on the number of probes that are used in chip construction, a different resolution is performed, and it is usually about 20 to 200 kilobases. The disadvantage of this method is that it can be used for analysis of balance and rearrangements or low-level mosaicism. So what we can detect with this method, we can detect a number of microdeletions syndrome. On these two slides, I put some most common microdeletion syndromes. But except this microdeletion syndrome, we can also detect other deletions or duplications. Actually, we are analyzing copy number variants, which can be situated anywhere in the genomes. Thus, we are detecting also copy number variants in in other genes, and after the analysis, interpretation is made by searching databases such as OMIM, Decipher, and other bases. Like I said, the main advantage of Cgh technique is that we are scanning whole genome, and that in one step we can detect and diagnose multiple malformations, syndromes, and other diseases. So when we are performing Cgh, like I said, first we perform karyotype, and when karyotype is normal, we are performing Cgh. The indications are actually all first trimester and second trimester ultrasound abnormalities. For nuchal translucency, guidelines we are using is that we are performing Cgh when translucency is higher than 3.5 millimeters, and for second trimester abnormalities found on ultrasound examination. Actually, we are performing it when any congenital anomaly is found on ultrasound, whether it is first trimester or second trimester ultrasound. Also, we are performing it in the case of fetal growth restriction. According to literature, Cgh reveals up to 6% clinically significant copy number variants when ultrasound anomaly is present, in comparison to 2.4% of detected CMVs when the ultrasound anomaly is absent actually in overall prenatal cases. This is one example in our laboratory. That was the pregnancy which on ultrasound examination, a bilateral tub absence was noted. Also, a common AV channel was detected as ventriculomegaly. Karyotype was performed, and it was normal male karyotype. Since we suspect the whole thorax syndrome at first, we also performed Cgh, and at Cgh we detected deletion of 4.7 megabases on chromosome 20. These deletion also encompass SALP4 gene, and disorders mutation of this gene are related to disorders such as Okihiro syndrome, acrorenal-locular syndrome, and Holt-Oram syndrome. After diagnostics were performed, termination of parents decided for termination of pregnancy. The second method we are using, the second molecular cytogenetic method that we are using is fluorescence in situ hybridization, or FISH. This method is based on the hybridization of fluorescently labeled probes to comparative sequence of DNA. This method is now these days less usually performed than Cgh, but still it has some advantages. Of course, in comparison with Cgh, it has smaller resolution, and only 200 to 300 kilobases deletions or duplications can be detected. These slides actually shows that before Cgh, we performed fish analysis for all chromosomal abnormalities that are lower than 4 megabases. Actually, these are abnormalities that we couldn't see or on microscopic analysis. But today, FISH is usually used only for array Cgh result confirmation or for mosaicism analysis. Still, FISH can be used also for microdeletion or microduplication syndromes. What is also the disadvantage in comparison to array Cgh, that we are using one strict probe. So actually we have to have some assumption of particular microdeletion syndrome. One such example is the George syndrome, which could be assumed after ultrasound examination shows tetralogy fallow or VSD and truncus arteriosus. Then FISH still can be performed. I mean, in comparison to array Cgh, FISH is still cheaper and easier to perform. So actually, if you are strictly assume on the George, then you can perform also for FISH. You can also use it for Miller-Dicker diagnostics, and in case when on ultrasound you found omphalochela plus ventriculomegaly, then you can also perform FISH or array Cgh. Now we are coming. When we perform, actually, we started with karyotype, then we are usually performing array Cgh. If these two analyses are okay, and we have a normal karyotype and normal molecular karyotype, then we are performing a molecular diagnosis. What is the problem with molecular diagnosis, and what is actually the main disadvantage is that when you are performing PCR or sequencing, you can perform it only on a specific target sequence, which means that you have to know what you are searching. Of course, when we are having familial cases of such diseases, then it's easy to perform the prenatal diagnostics. But a huge number of mutation causing such diseases arise de novo, and actually these are new mutations, and that's the problem. That's the main problem in prenatal diagnostics, how to suspect on such diseases, and that is the most important use of ultrasound or fetal echocardiography, that based on these examinations, we could suspect on particular genetic diseases. Like I said, for molecular analysis in prenatal diagnostics, we are usually performing PCR, classical PCR, or quantitative PCR, and Sanger sequences. Of course, these analyses are performed on DNA samples, and like I said, you have to know the sequence what are you searching for. By these molecular analysis, you can detect point mutations like deletions or duplications of one base pair or substitutions, but also you can detect gene deletions or duplications that are a little bit huger than actually until a couple of hundred of base pairs, which are of course about actually 1,000 times smaller mutations than that we are detecting with Cgh. Here are examples of genetic diseases that we can assume on US examination. One of the most common, especially in our European population, is cystic fibrosis. And cystic fibrosis is characterized by hyperechogenic ball plus ball dilatation. It is found that among all hyperechogenic ball findings in 3.1% a mutation of CFTR gene is found, and of course cystic fibrosis is diagnosed. When on ultrasound examination, arthrogryposis or different heart defects are found, it could be suspected on spinal muscular atrophy type 1, and in this case is DNA analysis of SMN and NIPE gene are performed. When you found polyhydramnion plus positional defects of extremities, usually it is meant on club foot, analysis of the MPK gene is performed, and mutation which causes myotonic dystrophy could be found. Now I want to tell you something about genomic imprinting and uniparental disomy. First of all, what is genomic imprinting? It's a phenomenon that particular genes are expressed depending of the origin of parent. Such as imprinted genes are expressed both in placenta, also in fetal tissue. What happens when this imprinting is malformed? Actually, we have uniparental disomy. Uniparental disomy means that both homologs of chromosome pair are inherited from the same parent. This could be a whole chromosome or just a segment of chromosome. There are different mechanisms of UPD, and I will show you, for example, of trisomic rescue, when actually we have a trisomic fetus, but then a trisomy is rescued and the wrong chromosome is separated, and in the end we have both chromosomes from the same parent. These uniparental disomy cause problems not for all chromosomes, but only for about 100 till 200 genes that are known that are causing diseases. When we are performing UPD diagnostics, usually when we have a fetal growth retardation. I have to say that there is no some particular ultrasound finding that is specific for UPD, and like I said, usually it's only fetal growth restrictions. Here are some examples of UPD that we found. Actually, maybe when you have a polyhydramnion and skeletal abnormalities, you can assume a UPD, maternal UPD of chromosome 14. UPD diagnostics is performed in several ways. Actually, we are using several methods. It's STR analysis, MLPA, or RACGH plus SNP analysis. In conclusion, like I said in the beginning, classical cytogenetics is still a gold standard, but when we have a normal karyotype, then we are performing also on molecular diagnostics. Of course, ultrasound is really helpful in making assumptions and choosing methods that we, molecular method that we will perform. Also, besides the ultrasound examination, really helpful are other screening methods such as biochemical screening or non-invasive prenatal testings of free fetal DNA in maternal blood. And that will be all for today. Thank you for your attention.
Well, Dr. Anna, that was really wonderful. I mean, I think there is a question from Dr. Yeah. Think about when to do fish and when to do full karyotyping. Can you answer? If you're online, Dr. Anna, Dr. Narendra Malhotra would really like to know.
Sorry, I don't hear you.
Yeah, sorry, Dr. Anna, are you online? Yes, I see you.
Yes, I'm online now. Yes.
Yeah. Dr. Narendra Malhotra wanted to say when really you want to like to do fish, where to go for karyotype or CGS and full genome sequencing in a clinical condition. What clinical conditions will correlate with this thing?
I'm sorry, can you repeat the question, because something is stopping me and I can hear you. Or you maybe.
So you just cleared indications for fish, indications for karyotype, indication for array, indication of whole genome.
Yes.
Briefly again.
Okay, briefly again. Actually, we performing karyotype as a first step. Actually, patients go to prenatal diagnostics for ultrasound or NIPT tests or maternal age. And if karyotype is normal, then the second method is array Cgh today, actually, because like I said in presentation, array Cgh covers whole genome, and with fish, we have to, we can test only the special sequence. So our second method is array Cgh, and then when if the array Cgh is normal and we don't found any mistakes there, then we are performing molecular testing like PCR or fish to confirm something. Actually, at the moment, we are not performing whole exome sequencing in prenatal diagnostics. Only in familial cases, when we have confirmed mutation, then we are searching with sequencing, but at the moment we are not performing it in prenatal diagnostics. Maybe it's too hard to perform whole exome or whole genome sequencing in prenatal diagnostics because a lot of unclear findings like VUS and interpretation is really hard. There is a difference between prenatal and postnatal diagnostics, because in postnatal diagnostics you have a patient and you can correlate these findings with the patient, and in prenatal diagnostics it's really hard because you have a lot of these findings which you can't interpret in the prenatal time. So at the moment, array Cgh is performed, and but molecular diagnostics like sequencing is performed when you have assumption of some particular genetic disease, like I said, cystic fibrosis or something like that.
Excellent. That is exactly the message which we want to go. which should go clearly to all those viewers. Very well presented.
Yes.
Thank you very much for being here
Thank you.
and sharing all that genetics to us and simplifying things.
Okay, thank you very much.
Thank you, Dr. Anna. Thank you very much. Thanks, Dr. Erika.
Dr. Anna. Excellent.
Thank you so much, Dr. Anna, and thank you, Dr. Deepak, for chairing this session. Let's go ahead to our next session, session 3, invasive testing. For this, I would now call upon Priyankur, our coordinator for the next part. Dr. Priyankur, over to you.
Thank you so much, Niharika. It's a pleasure to be part of this program and a wonderful session that's going on already. 2 wonderful talks that we had on the pedigree charting and the importance of ultrasound in screening of fetal genetic conditions. So now for the next talk on invasive testing, we have our chairperson, Dr. Asha Bakshi, ma'am. Can I have a CV, please? Yeah, Dr. Asha Bakshi is the director at the Disha Fertility and Surgical Center in Indore. She is the vice president-elect of FOXY, and she is also the chairperson of the AICOG 2022 going to be held at Indore. Ma'am has organized various conferences and is a invited faculty of many, many conferences. Can I request Dr. Asha Bakshi, ma'am, to kindly invite our speaker, Dr. Raju Saitya, for his talk on invasive testing.
I can't see Dr. Asha here right now, so maybe we
You'll introduce, please. You introduce.
Okay, sir. Sure. Thank you, sir. So we now go ahead with our introduction of Dr. Raju Saitya, in invasive testing. Sir is the president-elect of the Association of Fellow Gynecologists. He has been the past president of ISPAR, executive member of the MOGS. He has received various awards from various platforms, including the Dr. S.N. Shirodkar oration, which he delivered at the annual AICC RCOG conference at Solapur. It's a pleasure, sir. You're there with us today, and we are all waiting to learn from you and listen to your talk on invasive testing.
Thank you very much, and thank you for that kind introduction. At the onset, I would like to thank Dr. Rohana, my friend Dr. Narendra Malhotra, Niharika, and all of you for having here. It's always been a pleasure talking about invasive testing and teaching one and all. Can I share my screen now? So how we go? This is a I have already clicked on share screen. Okay.
Raju, sir, I guess there's a bit of a connectivity issue on the side. We're not able to see the slides, nor are we able to hear you, sir.
It's not happening. No. I was able to get the problem. I think you have to stop sharing. There's already thing on the screen. Hello.
We can see a screen now, sir.
You can see, but I should be able to see.
You need to minimize this window, sir.
Sorry?
I think Dr. Raju has connected twice. So he'll have to leave
Twice?
once. I think he's connected twice to the same from the computer. That's why the echo is coming also.
Yeah, but that got resolved.
No, but by the computer also you connected 2 times.
Okay, I will leave once.
Leave once and rejoin.
You cannot start your video because the host has stopped it. Okay, that's one thing. Now I will leave. Is it okay now?
Yeah, it is okay. Now we're not hearing the echo. Now you share the screen.
Yeah, okay. There is that I share in circle, not
We can't see the screen yet, sir. So I guess there's a little bit of a... It's getting...
right there.
In case if... So we cannot see the PPT yet, and your connectivity is still getting stuck in between. So could we go ahead with the panel? Maybe after the panel, take your talk, sir. Naren sir, with your permission, can we go ahead with the panel and then take the sir's talk, because the connectivity looks a bit of a problem.
Yes, I think we can go ahead, because and Dr. Raju should log out of all and then log in again from 1 and open his slides full screen. So we can start the panel. Yeah.
Sure, sir. Thank you so much. We'll go ahead with the panel discussion, an exciting session that we are looking forward to, which will be moderated by none other than Dr. Naren Malhotra, sir. The panel is on prenatal screening and diagnosis, what test, when and why. So the moderator of this panel is none other than Dr. Naren Malhotra, sir. I usually introduce him by just saying one line. He has held important positions, mostly past president right now or president of various organizations in India and across the globe. So welcome, sir, to this platform. And it's a pleasure you've given us youngsters like me and Niharika opportunity to be part of this wonderful session. Thank you, sir. Our esteemed panelists, experts for this session are Dr. Firoza Begum. Can I have the next slide, please? Yeah. So ma'am is a reputed obstetrician and gynecologist in Bangladesh. She has been the founder president of the Fetal Maternal Medicine Society of Bangladesh. She is the ex-editor of the Bangladesh Journal of OBGYN and has been the treasurer of the Endometriosis Society of Bangladesh and the Fertility Preservation Society. Welcome, ma'am. It's a pleasure to have you with us. Next with us, we have Dr. Iris Antelis, sir. He is from the University of Athens Medical School in Greece. He has been the president-elect of the European Association of Perinatal Medicine. He is the co-editor of the Donald School Journal of Ultrasound and the editor of the Greek journals. He is the vice president of the Mediterranean Union in OBGYN. Welcome, sir. Next with us, we have Dr. Yusuf Latif Khan, currently the Secretary General of SAFOG, is a professor at the Rashid Latif Medical College in Pakistan, Scientific Secretary of the IVF Society of Pakistan, and the General Secretary of the Society of Gynecological Endoscopy. Welcome, sir. Next with us, we have Professor Farooq Zaman. He is a renowned gynecologist practicing in Pakistan. He has more than 36 years of experience in the field. Currently is offering consultations to his patients at the Hamid Latif Hospital in Lahore. He is involved in raising He is involved in raising awareness for the reproductive health of women. Welcome, sir. Next with us, we have Professor Atula. He is a professor at the faculty of professor at OBGYN at the University of Colombo, president of the Medical Faculty Teachers Association. He has been the member of the organizing committee of international conferences which have happened in Sri Lanka and elsewhere. He has been the member of the National Council as well as the member of the Medical Committee of Family Planning Association of Sri Lanka. Welcome, sir. And last but not the least, we have Dr. Vataganara with us. He is an associate professor at the Department of OBGYN at the Shiraj Hospital in Bangkok. Sir has been an executive board member of the Medical Ultrasonic Society of Thailand, and he is currently the associate fellow of the Indian Academy of Parental Medicine and also board member of the Medical Maternal Fetal Medicine Committee, AOFOG, as well as the board member of the International Fetal Medicine and Surgery Society. Welcome, sir. So I welcome all the panelists, expert panelists to this session, and I hand over this session to our moderator, Dr. Narendra Malhotra, sir, to take us through the next hour, sir.
So very good evening to all of you. It's indeed a pleasure to moderate this panel and be a part of this CEPHOG's programs every 2 monthly we're going to do for 1 year. So I welcome Dr. Firoza Begum, Dr. Iris Santakis, my friend, Dr. Farooq Zama, our teacher and guide, Dr. Atula, and Dr. Vatagna. I hope all of you are there. You can say hello.
Hi, hello.
Yeah, Dr. Firoza was there. Dr. Farooq is also there, and Dr. Atula is.
Yes, I am here. Right.
So all are here. And you could put on your videos. So, ladies and gentlemen, first to the panelists, the first question is the risk or the problem of genetics big enough to offer a screening test to all the pregnant patients we see? Or should we do it only to the risk? One line from all of you. Dr. Firoza, we start with you.
I think, Dr. Narendra, this is a woman's right. Because most of the problems we identify actually in the maternal or fetal part late in pregnancy. So when we have to struggle for the monitoring. So if we can identify the problem earlier, it would be better. Thank you.
I'll request Dr. Raju Sahitia also to join in because we'll be coming to the amnio, so you can also. Dr. Farooq, what do you say? In Pakistan, how do? You offer it to everyone or on higher risk?
In one sentence, I will say that in a perfect world, we would, but according to resources and according to facilities, starting with the history, ultrasound and onwards, whatever facility is available, that should be employed.
So it depends on the facility, especially in our CEPHOG country. Dr. Raju, what about you? You are in Bombay. You do it for everyone?
Yeah, for us, it is universal because if it's in the doctor's mind talking about resources and whether the patient will be able to afford. But if you have a problem child, the same patient is going to tell you, who told you that I can't afford? I would have gone and done my screening, dual marker, ultrasound, anomaly scan, whatever was required, invasive thereafter, but you had no right to decide that I don't afford. So in Mumbai, my practice is universal screening, and that is the right way, I think.
Professor Aris Antakilis in Greece, and Dr. Atula from Sri Lanka, and Dr. Vatnagara from Thailand. From all of you, if you're there.
Yeah, I think it's or even if it's not a big problem, I think it's an important thing to offer this because from the patient's point of view, it is very important for the patient to know that the baby that she is carrying is normal. I think that is something that is very important for us to work towards and offer these patients some kind of screening. Yeah. With using whatever the facilities you have.
I don't think the other two have joined in. So we come to Dr. Yusuf, the Secretary of CEPHOG, because after this, we're going to come out with a guideline on what CEPHOG countries should do. So what do you think, Dr. Yusuf? How do you go about pregnant women, screening them?
Thank you, Dr. Narendra. It's always a pleasure to be here. My point of view would be, yes, we can do it the non-invasive part for everyone, but not the invasive part for every patient we have here because of the resources and the facilities which we have here in our part of the world.
So let's see what the problem is. One Indian study told us at birth we have about 2 to 5% abnormalities, 0.5% chromosomal abnormalities, and 0.6% single gene defects. And worldwide, 1 in 800 baby will be born with Downs, 1 in 10,000 with Edwards, and 1 in 30. These are the commonest ones, because the rest major chromosomal anomalies, the babies abort or they die before birth. So we are very worried about these three, because these babies will live and live considerably up to the age of 40, 50 and be a burden. So, sir, Dr. Farooq, is Down syndrome screening only enough, or should we do it for all of these? Especially our countries, we can't afford to screen so many and spend so much money. So you think only Down syndrome would be good enough?
You see, on ultrasound, when you are looking at nuchal thickness, as a matter of fact, that's a pointer towards all three of these trisomies, and therefore, and couple it with the history. Initially, if you look at it from the standpoint of age, if the patient is beyond 35, of course, you will do it for all. But when NT started off about 20 years ago, it was only meant for women over 35 years. But as it became more common, now it is done for everyone, because more than 50% of patients are below 35 with Down syndrome. But when you are doing nuchal thickness, you can look at all these three. They can be pointed at.
So what sir gives a good message is ultrasound you're doing, look for everyone. Now let's come to Dr. Firoza Begum. Everybody talks there's a pyramid of prenatal care, and it has been inverted. What do you mean by this? Pyramid has been inverted.
Inverted pyramid because previously we gave care to every woman. As the date approaches, we gave frequent visit to the woman. Now we know in the early, by 12 weeks of gestation, we know what is the problem with the woman, and we can concentrate all our effort to this woman, and we do not need to come other low-risk women to come frequently to us and do some testing or investigation. So all our energy, all our efforts will be directed to those who are the high-risk cases. This is the inverted pyramid.
Dr. Atullah, can you add now? Professor Nicolaides added a penthouse on this pyramid and a basement. So do you think these two are also equally important than the 11 to 13 weeks that Dr. Firoza is saying?
Yeah, I think those are my feeling. Those are also equally important, because the prenatal pre-pregnancy issues in terms of looking at all these non-communicable diseases like diabetes and many other disorders could contribute to problems in the fetus in the part as well as throughout the pregnancy. So it's very important for us to look at these from the point of pre-pregnancy assessment and counseling. And also from the other end, after the pregnancy, it's also important because it affects the long-term health of the woman and is an opportunity for us to look at the long-term health of the mother as well.
Because now we've come to the era of non-communicable diseases rather than infection. Dr. Raju, how do we screen? For aneuploidies, for anomalies, for preterm births, for preeclampsia. These are the four things we want to screen in every pregnancy. Aneuploidies.
So adding to something about the turning of the pyramid of prenatal.
Yeah.
Earlier, many 100 years ago, the antenatal care was for the elite and the royals. And in UK, the protocol which was there, the world followed it for more than 80-90 years. And we were not wrong. Taking blood pressure, fundal height, seeing that the fetal heart sounds are fine, and seeing that she's put on weight, that is what we could offer that time. And we had nothing more to offer that time. But with the changing trend and the turning of the pyramid, the first 12 weeks of pregnancy says it all. And therefore, more frequent visits, maybe every 2 weeks, and doing an Oscar. Oscar means at 12 weeks, one-stop counseling and screening. And screening means combined screening. Therefore, ultrasound goes with it. When you do combined screening, you have the age age have sensitivity of just 30%. But when you go ahead and do a dual marker and do these two, PAP and HCG, your detection rate increases. And when you add the nuchal translucency to it, and we have touched close to 90%. So that doesn't mean invasive tests are going to reduce. Earlier, invasive tests were offered to those who were above 35. That
all above 35. That's how we learned in Singapore. So we'll come to this point. Let's ask one by one. For you, how do you screen for aneuploidies? I mean,
so we start when the patient comes, when we register the patient, and after congratulating her, we have to tell her that you are lucky that you are in an era where we can detect major problems which can happen. So aneuploidy screening will be there, like what I said, at 12 weeks.
So what he just said, he just told us ultrasound, biochemistry, and maybe cell-free DNA at 12 weeks mainly, or maybe second. Dr. Yusuf, about anomalies. How do you go about screening for anomalies? Because chromosomal anomalies are different, structural anomalies are different.
And I think for the anomalies, the tool you developed is by the grace of your ultrasound, which has gone so high, and initially doing the nuchal translucency first, and then doing it. So they provide a good kind of things to kind of rule them out, and of course at 20 weeks again, 20 plus weeks again to diagnose the other cardiac and other.
So 12-week anomaly scan and 20-week anomaly scan. Dr. Firoza, preeclampsia.
In the first trimester, actually, in Bangladesh, if you ask me to tell what we do in Bangladesh, actually we take very good maternal history, mean arterial pressure, uterine artery Doppler, and biochemistry. Actually, here we don't do, but then I have already mentioned the uterine artery Doppler. This is in the first trimester.
So because biochemistry is still not freely available in developing countries, we can go about with all. Dr. Atullah, preterm birth, can we screen in the first trimester, second trimester? We all do.
We'll do mainly the second trimester. We would do the cervical length assessment in terms of looking at preterm birth, and that's the facility that we would have here.
So here are the 4 diseases which we screen. Dr. Farooq, you can summarize aneuploidies, genetic, and then structural anomaly, PA, which all pregnancies should be screened for.
Yes, ideally speaking, all these should be screened in the first trimester. And as the advances are being made, more and more diseases, more and more conditions are being included, which can be identified or which can be suspected, so that one can take preventive measures against them. But as far as facilities are available, first trimester ultrasound, that should be there, and that takes care of quite a few of these things. And as the expertise also grows, then identification or screening for preeclampsia also is there. So after aneuploidies and anomalies, preeclampsia is included in that. So far as preterm birth is concerned, at least from history, if that is suggestive, it can be suspected at that time, and further evaluation can be carried out according to that.
So these are the 4 diseases. Now, Dr. Raju was talking a lot about biochemical markers. Here is a picture of a fetus, and I'm sure he's going to explain to us where all these markers come from and what will they. Very briefly, Dr. Raju, the 4 biochemical markers and nuchal translucency, you said you combine all of them to get the best. So your placenta gives.
This is so very well illustrated. I love this slide, Naren. I always also have it in my presentation, and it is so very clear that as the fetus develops, you are seeing things which are happening inside the HCG, the inhibin A and the PAP-A, and the alpha fetoprotein which comes from the fetal liver, and the unconjugated estriol from the adrenal. And when at Oscar at 12 weeks, between 11 and 13 weeks, if you go and measure and relate to the gestation, the nuchal translucency, you can define whether things are all right or you have to further do something for this pregnancy.
So this is where in the placenta here below papae, we can also add PIGF and S-FLIT, the two new markers for PIH. If the placenta is not functioning well, it is HCG, inhibin, papae, PIGF and S-FLIT which will go wrong. If the liver does not develop because of 13, 18, 21 trisomy, the alpha-fetoprotein MOM will go wrong. The adrenal unconjugated estriol will go wrong. The lymph vessels which connect the head to the thorax will get blocked here, lymph will collect, and this will appear as nuchal translucent. So if we understand this, then we can understand what biochemical tests. So let us talk to Dr. Atula now. What is a screening test and what is a diagnostic test?
Well, screening tests is we would be performing in the population, which is generally almost all screenings are non-invasive tests, and they would only give you a possibility and give a risk assessment, which is not confirmatory, and it's not 100% diagnostic. Whereas a diagnostic test.
So I have seen pregnancies terminated at NT3. Would you say that, or 4?
No.
No. So NT is a screening test. It is not a diagnostic test. It does not mean baby is abnormal. So Dr. Yusuf, what are the diagnostic tests? What is a diagnostic test? You unmute, please.
Sorry.
Yeah.
Sorry. Yeah, diagnostic tests are those tests in which you need to kind of reconfirm, just as you said, that if NT comes out to be 3, you don't need to jump into this and terminate the pregnancy. You need to do those invasive tests done, which will actually confirm 100% what actually the situation is. But of course, the disadvantage that they carry their own complication rate with that as it goes on, and not many people have the facilities or the expertise to do those tests as well.
So that has had to be kept. So the prelude for our countries is that we should offer, up till now, what the panelists have said, we must offer screening universally. We must do a proper counseling before, a non-judgmental counseling. That is, if your NT comes high, you will not be terminated. You'll have to go for another test, something like that. We should tell them the limitation, the risk, the cost, and the benefit of the test. And after the test report comes, do a counseling. And we should give a lot of leaflets, videos, infographics. And we in India, from Foxy, made a genetic screening protocol. Patient comes pregnancy, we tell her what tests are available. She has a choice of accepting them and not accepting. If she says, I don't want any genetic test, fine, antenatal care. If she wants, then if she's in first trimester, we go for combined screening, as Dr. Raju said. If she's in the second, NIPS or quadruple, and low, high, and intermediate risk, can we go ahead and do a genetic test? This is what we follow. And this is, so let's come to the maternal serum markers, which you just saw. So first trimester, Dr. Firoza.
First trimester maternal serum PAPE and free beta HCG, this is commonly practiced. And
PAPE and free beta HCG.
Yeah,
and
but
second
you can
trimester,
add the quad markers, alpha fetoprotein, but you can add alpha fetoprotein in the first trimester. And
fantastic.
Also,
we will come to that, because that is
also in the first trimester we can add.
So Dr. Raju, you were telling us how these combined tests tell us the risk. Now in the first trimester, I've done a PAPE, beta HCG, PIGF, and alpha fetoprotein. And then I added NT. So see, your detection rate went up to 80/9. Can you explain how this performs?
Because
this is our Indian study.
This is what I meant when I said that when you do a combined testing, if you take age alone, you have 30%. If you take the biochemical markers, the two, PAPE and beta HCG, you may go up to 65%. But when you add PIGF and alpha fetoprotein, you go up to 80%. But when you do an ultrasound is a game changer in the sense identifying this nuchal translucency and relating to the millimeter of CRL of that fetus is going to tell us up to 90% and more, and that also with false positive rate of less than 1.4%.
That is what is important. The false positive will come down to 1.4. So you are not going to make a false positive diagnosis. So what is
like what you said, nobody should terminate. Nobody should terminate, because if you terminate, you may land up repenting if everything is all right. Therefore, these are the patients who should be counseled that this is screening. We have to go for diagnosis. And unless diagnosis is done, we should not terminate.
So in India, I'll like Raju to continue, and I'll ask you all whether this is something like this is available in your countries. In India, we have what we call as the Be Happy test or a Penta Marker test that is extended. And Be Happy test, can you explain? See, it is like this, Raju, Dr. Raju Sahatia.
Yeah, so, Be Happy is very well abbreviated here. The blood pressure is so very important. It is age old, and we've been doing that. Extended clinical history. You have to know whether this family has...
As Dr. Farooq Zama emphasized, history is very important.
History is very important, and history-related counseling is even more important.
Yes.
Unless you not tell the patient may not be able to decide what good you are going to do for that patient. If you don't counsel, and if you just say that, okay, you had one Down syndrome, okay, let's go ahead. You have to go into the history of miscarriages, because miscarriages earlier and now is a lot of difference. Now there are so many, in RPL we are going to see so many aneuploidies. We are going to see trisomy 18, 13, which can be blamed for these mishaps. So it is so very important. And then of course, age for beta HCG, alpha fetoprotein A, PAP A, P, and PLG.
And your first trimester ultrasound. Now notice here, ladies and gentlemen, notice here, we have 4 biochemical tests coming in first trimester. So it's a quadruple test in the first trimester also, not dual marker. Dual marker was only HCG and PAP A. So we have quadruple marker in first trimester. Dr. Firoza, what do you say about this?
No,
you said alpha fetoprotein in first trimester.
Yeah, I would be very happy, Narendra, if these markers, actually we could do these tests here. But what we could do in Bangladesh, actually we are doing only ultrasound in the first trimester between 11 to 13 weeks, 6 days. And we see the cervical length, fetal anomalies, as well as ductus venosus Doppler, uterine artery, and everything, tricuspid regurgitation. We give note about everything. But serum marker actually we don't do. So if we could do this serum marker, that would be better.
So we will come to that. And the other company in India offers what they call as the Penta Marker. It is all the same, and the detection rate goes up to over 95%. So these are the 2 companies. We have this in India. It is not expensive. It's only 4,000 or 5,000 rupees, Indian rupees. So it's not very expensive. Now we come to our CEFOC countries. Dr. Farooq, Dr. Yusuf, because biochemical test is not available everywhere, as Dr. Firoza is saying, India is fortunate that we've got it now. So how do we do? So first thing, maternal risk by age. We were taught like this. Everyone over 35 do amniocentesis.
No.
No. I don't think so.
Not anymore.
So that is what we were taught, but we don't do this. So you give a risk, you give a score, 30% it will be. And then you put the ultrasound first in our countries and biochemical markers if we have. And then you modify the risk. And then you do the amniocentesis or chorion biopsy. So Dr. Farooq, something like this will be okay for our countries?
Yes, absolutely. I agree. This is a very practical method of approaching the situation.
Yes, Dr. Yusuf.
I think there's also one thing which we do face here in our country, and maybe maybe in Bangladesh also. Okay, the patient, whatever they say, even if there's an anomaly which comes out, we don't want to get terminated. And in those cases, then there's no point of doing this invasive testing at that point, because if they're not willing to get the pregnancy terminated and want to carry it on, then I think we'll just stop at this, the modifying risk factor.
So lethal anomalies, yes, you can offer them termination, but non-lethal anomalies, I think they deserve, but it is the patient's choice finally.
No,
now let us come to the time. So you have tests before 14 weeks and after 14 weeks. Unfortunately, we have no test for 14th week. So 1 week is gray zone because the mom values are not there. And these are the type of tests which you can put. NIPS you can do from 10 weeks to 20 weeks onwards till 20 weeks. But otherwise it is quadruple marker when the BPD is more than 30, that is second trimester, that is 15 weeks. And when CRL is 45 to 84, the first trimester markers, which is dual marker or quadruple first trimester marker or an extended test. And all of us should know ultrasound because ultrasound is easily available. Biochemical is not available. So then we do the risk. So can someone explain if it is high risk, CVS, intermediate risk, take to second trimester, low risk, leave it alone. Dr. Firoza, do you do this?
Yeah, when I screen, I first take the history and the previous history along with her age, and then we do the anomaly scan. If it comes low risk, I actually don't do anything. But if she has a previous history of Down syndrome or some anomalous baby, and we actually do anomaly scan, I do NIPT for these patients, and accordingly I decide whether I will go for invasive testing or not. And I do here want to add one sentence that in Bangladesh, actually patients are not that much adamant that we will not terminate. No, the things has changed. People now agree to terminate if there is an anomalous baby.
So you said NT, DV, TR, we need not do all that, but if you are only dependent on ultrasound, then you have to do all of them.
Yeah,
so
we do everything.
So we suggested that you should do ultrasound and follow it later on by the biochemical test. So the Indian or the scenario would be, if you have the Be Happy test, do that and make your risk assessment according to that so that you get a 90%. So in India or in developing countries, we should do combined test, biochemical with ultrasound, or only ultrasound and then do a biochemical, because if it is not available, and if it is still not available, then take it to the second trimester genetic ultrasound and then you do the complete. But the proposal is combined test, ultrasound, NIPS, alpha fetoprotein and preeclampsia. Now let's come to the second trimester. So what would you do in second trimester? Dr. Raju Saitya?
Second trimester, after knowing the risks of the first trimester and explaining everything, it is mandatory to do second trimester fetal anomaly scan. Although the scope of first trimester 12-week fetal anomaly or anatomy scan is what we should aim for, but there are certain things which will develop little later. So anomaly scan in India, we have to complete it before 20 weeks. Although now the duration for termination has been extended to 24 weeks, but it is with due permissions and all. So by 19-20 week scan, we have to establish the normalcy of this fetus, and then we have to have a relook ultrasound at around 24 weeks, because certain things like the cardiac anomaly, the renal anomaly, they can be better dealt with and identified at 24 weeks. So it is very, very important to keep this in mind.
So Dr. Atula, would you suggest triple marker now? Still a lot of people are doing triple marker.
Unfortunately, locally, we have very limited facilities to do the serum markers because it's all available in the private sector at a very, very high cost, and it's very limited. And we totally really depend on ultrasound as well. And we have another problem in Sri Lanka because still, unfortunately, termination is illegal. So going from screening to confirmatory diagnostic tests really is being used to prepare patients to accept the situation and look at space and legally become terminated pregnancy.
So that seems to be a total problem. India also had this major problem of biochemical tests. Unfortunately, we have it good now. So if you do the first trimester double marker and ultrasound and a second marker quadruple and an anomaly scan, you get a detection of 93%. And the anomaly scan, it will be done in the head, the bowel, the limbs, the cardiac, the spine, the nasal bone and all. And that requires some ultrasound expertise, which is easier to learn than having a lab. And then we'll put them into, here we don't have intermediate risk. Here it is high risk or low risk. And if you find an anomaly, then straight away amniocentesis no quadruple marker or no NIPS. So that is what we do. Now, because in India, the termination is legal up to 24 weeks, so that, and we should not terminate on screening. Now let's, Dr. Firoza, this is what I heard you talking in Bangladesh. After screening, what?
For screening, we advise the patient, if we found her in a high-risk group, we actually counsel the patient for invasive testing. That is in the amniocentesis, and the lab is not available in Bangladesh, so I have to send the sample to India. And there are some agents we can send the sample to India. Even the blood test, actually, we send to India.
Doctor, what do you do in Pakistan? CVS and amniocentesis freely available, not available? Screening test is positive. What do we do then?
Ultrasound is now widely available, but CVS is not available so widely. And it's only available in limited centers.
What, Dr. Yusuf?
Yes, I think Dr. Farooq said in the main cities, yes, we can manage to get these two tests done, but not in periphery on this. But we do have the facility of this Harmony and NIPS test available that we can send it to abroad and get them reports back, which we do get in about a week or so.
What about Sri Lanka, sir? Amniocentesis CVS?
Yeah, amniocentesis, of course, it's available in quite a few centers. It's a straightforward procedure in terms of doing it, but not CVS. It's very limited.
So now we have done an amniocentesis. So what to do with that amniotic fluid? And we had a lovely talk just before this. You can do FISH, you can do PCR, you can do quick PCR, you can do array, you can do chromosomal array, and you can do a whole gene sequence. So we should know what these tests can diagnose, then only we should, because amniocentesis sample you have to send to the lab and ask them to perform what? What should they do? So Dr. Firoza, how should we ask? What should we ask?
I actually give the history to the, with my advice. I provide the history that this patient has got this history, and accordingly what they need to do, whether it is a karyotype, whether it is NGS, whether it is single gene defect, accordingly the lab, I actually advise them. If it is a single gene defect, I will advise sequencing. And whether it is a chromosomal abnormality, I will advise simple karyotyping. So I actually give the history and advise the test.
So that is very important for the clinician, should know who's taking out the fluid, what tests they are asking for. Now, lastly, we come to the 3 types of testing which are there in the world. And I will show you all the 3, and I will ask you what should be the CEPHOG approach. First is the integrated testing, fully integrated. That means you test in the first trimester by ultrasound and by only PAP-A. Don't do the rest. In the second trimester, do the HCG or the quadruple marker, and then do the risk and terminate or do a diagnostic. This is the first, integrated. Second is sequential. In the first trimester, do a double marker and an ultrasound. Make a risk of high and low, no intermediate risk here. And then the second trimester, those low risk, again do a quadruple test and then MICA risk. High risk, do a NIPT, CVS here, first trimester. And the third is the first trimester double marker or NT or an extended combined test. If it is low risk, nothing except ultrasound at 20 weeks. If it is borderline, take them to other tests. And if it is high risk, do a CVS. So what do you think is suitable for us? Professor Farooq Zaman, what is suitable for us? Because we should.
I would say that stepwise approach is that's more practical, and that will identify in a better fashion the abnormalities, and that also will point out whether further investigations are required or not. So I would go for establishment of stepwise.
The one which you are showing on the screen.
Yes, that's right.
Because 80% will come low risk, and 10% will come borderline risk. And only 5 or 10% will come high risk. So if you scan 100 patients of 35 years, only 5 or 4 or 5 will require, or maybe even 2 will require a CVS or amniocentesis. The rest all will be filtered out. So our invasive testing will be minimized. Agreed, everyone, or any other opinion? Dr. Raju, Dr. Yusuf, Dr. Feroza?
No, I agree.
I totally agree.
Dr. Atula?
Yeah, that's what I would also suggest.
So this makes sense. So then our genetic screening protocol, which we should apply for CEPHOG, pregnancy, tell them about screening tests. They can accept or not accept. Is still, it is not compulsory. If they don't accept, do antenatal care. If they accept, if they are in the first trimester, do a combined test, or first trimester, or if you have a non-invasive prenatal screening, NIPS, do that, cell-free DNA. Second trimester, they come quadruple, high, low, and if low risk, only ultrasound. If high risk, invasive test. Ask for QF-PCR, FISH, chromosomal array, depending on what you want to know. And if it is intermediate risk, you can do NIPS again or do a straight away amniosis. So this is what we simplified as, and I think we will come to a consensus. If we can do something similar for our CEPHOG countries. Any comments on such a testing, sir?
Narendra, what about the biochemical test? What is your suggestion regarding the biochemical test?
So biochemical test has to be added in the first trimester screening. And not only dual marker, not PAPI and HCG, you have to add alpha fetoprotein and PIGF. Okay. So you get a 93% predictive value with 1.4% false predictive. So first trimester, 11 weeks, NT, 4 biochemical markers, blood pressure, and then you make the risk.
I think we should simplify, and like what we said earlier, a good history taking, which means age and previous obstetrics mishaps, and followed by a simple dual marker, which is going to take us to almost with NT to
80%. Yes.
Yeah, 90% when you take NT as well. Now, when you will advise such a patient for invasive technique, you should not shy from doing so, because these are the patients earlier when, like what we said, that 35 plus we used to do amnio, and we used to with great difficulty see one abnormality. But now after screening, when we do invasive technique and we are clear by 90% or 93%, those 7% deserving invasive technique, we will see that out of 10 amnios or chorion biopsy or placental biopsy, you are going to expect at least 5 to 6 abnormalities, because you have screened and filtered all those who are supposed to be normal, and you have picked up the high risk patient. When you say call them high risk, means there's a possibility of aneuploidy. 93 minus 7%, you will find 10 such patients, 5-6 patients will be reported aneuploidy. And that is what is an advantage of NIPS also, NIPS, because the sensitivity index there is almost 99.9% for Down syndrome. Now just imagine that 0.1% and you are going to tell them to do invasive technique. What will happen? 9 out of 10, there is a possibility that they will be reported abnormal. So we have to not shy off from, and one thing more, I believe, I don't do a repeat screening test. One screening test which is done, basis of that I will counsel and I will tell them. If they don't agree, I have to take a signature from such a patient that she was advised. You do one screening test, then you go for quadruple, penta. You know what will the patient?
No, that should not be double waste of money.
It is confusing yourself and the patient, because patient is going to ask you, why was the first test abnormal?
So in the future, the screening would come down to only NIPS very soon, because we'll be able to do PCR on NIPS samples and study all the chromosomes.
Yes.
And we could probably be asking for karyotype from NIPS, from mother's blood. So no needles, no nothing, no expertise, just take out mother's blood and send it NIPS, you get 99%. So future of screening is NIPS. Till then, we should do ultrasound in developing countries, add biochemical markers where they are, and offer the best to our patient. So thank you very much, ladies and gentlemen. Just the last slide by Professor Kuriaki just gave me this. You see the anomalies, 5% are environmental, 25% chromosomal, 20% single gene, and 50% structural defects. So what Professor Kuryak said is, if you do a NIPS, you will pick up about 75% chromosomal disease. If you do amniocentesis, you will pick up all the chromosomal defects plus about 30% single gene defect. If you do ultrasound, you pick up everything. So for our countries, developing countries, ultrasound freely available, only we have to learn to do it correctly and get certified by Fetal Medicine Foundation for nuchal translucent nuchal bone so that we can pick up almost all the anomalies. Thank you very, very much, panelists, for this wonderful discussion. And I'm sure we've given some very, very good messages to the
Thank
Dr.
you.
Priyanka, all yours.
Thank you, Narendra.
Thank you very much.
I would like to add, Narendra, here for
The session.
a comment about the way you have conducted this meeting. It's been absolutely fantastic. And I would congratulate you on organizing this important event for SAFOG. And we had two wonderful lectures to begin with. The first one, which was given by Dr. Manjeet Mehta, that introduced the genetics to all who were attending it. And then the second about importance of ultrasound in genetics by Dr. Anna, that also was very revealing, and it told us about all the different tests. And the panel discussion that you conducted, you had raised very important and relevant, pertinent questions, which are there in the minds of all the clinicians. And I'm sure that the proceedings of this, when they are distributed, they will be helpful to all the clinicians in this region of the world. Thank you very much.
Thank you, sir. Dr. Firoza and me will make the proceedings with Dr. Raju's help.
Yeah, thank you very much. You should send the proceedings to the society so that we can distribute all over the country.
Narendra?
Yeah.
Can we try connecting that invasive techniques? Because I look, that is so very important, because that fear of invasive has to go. Invasive technique is so easy that shy of, because like, if you don't know CVS, you tell the patient to wait till amnio and do a difficult abortion and vice versa. So I think, this is time that, like how we are progressed, learning all the screening, invasive technique is so simple to learn, because there is one simple principle, ultrasound principle. Let us try to connect. If successful, I would like to run through that PPT and explain.
Sure. There is a question in the meantime, abortus, what should we do? So for abortus, yeah, Raju, you can start connecting. Right. I'll answer the questions.
No, but has this
abortus,
earlier
product of conception, karyotype will not work, because for karyotype we need live cells which can multiply. So you should ask for CMA. So and parental karyotype we will ask if there is a structural defect in the POC. Do you agree, Dr. Firoza?
Yeah. What did you ask?
Abortus. How do we test the abortus? POC, product of conception.
Yeah.
Yes, Dr. Raju is connected, so he can quickly take us through how to do
microarray for product of conception, chromosome microarray, because there may be maternal cell contamination. So
that is clear now. Microarray should be asked whenever you sending POC. Yeah, and someone is asking, recording will be available and will be sent to all. The recording will be available in 2 days and we'll circulate to everyone. And you will also get a certificate with 2 credit points for attending this. Yes, Dr. Raju, you are loud and clear. Let's go through this quickly.
I'm glad we could make it. Now let's go ahead with it. Quickly, I will run you through. So we dealt with this so beautifully. Screening, counseling, ultrasound, biochemical markers. And we identify those who are low risk and ongoing low risk pregnancy. We continue and we deliver them. But if we find them at high risk, then the high risk aneuploidy has to be checked for, and we do this by doing chorionic villus sampling, or we do an amniocentesis, and it is very, very important to know the post-test counseling. What are you going to tell the patient? That is so very important. So like what we emphasized, now the game has changed. Earlier it was 35 plus, all should undergo invasive testing, or if there is a family history, or if there is a medical history. But now screening, and those who are high risk, NIPT, those who are at high risk, and ultrasound screening with soft markers. So these are all the screening tests. We have to tell the patient that these are screening tests. You get 1 in 100 or 1 in 200 or 1 in 1000. We have to see that you are not that one, and you are not affected with abnormal pregnancy. So that is the time you have to open your eye. You have to open your eye to visualize these chromosomes and to identify Down syndrome and other trisomies, chromosomal abnormalities, and genetic diseases and other conditions. So like what we said, fish is a rapid diagnosis. You don't require to culture, and you can in 72 hours know about the important common affected chromosomes, that is 21, 18, 13, and sex-linked chromosomes. So this can be reported in 48 to 72 hours. Of course, karyotyping, and we should never miss to do karyotyping. Whenever we do a screening, when we do fish, we should not just take a shortcut, because fish, those 3 chromosomes and sex chromosomes may go normal, but we should take advantage by doing a complete karyotype, and you will find some other abnormalities popping up. Of course, the microarray, there is no challenge to microarray at the moment, because this can really magnify and tell you all about, like what Dr. Anna discussed. So in India, it is governed by the Preconception Prenatal Diagnostic Act. We have to do, those who are following this act, and it should be done at centers which are registered for ultrasound and genetic clinic by a registered, trained and experienced practitioner. So what are the common invasive tests what we know of? We know of amniocentesis and chorionic villus sampling. Chordosynthesis is now less often, and it comes into requirement only when amniocentesis and chorionic villus sampling results are unconclusive. So this is roughly about the history part, and ultrasound is the game changer. It was introduced in 1950, and in clinical practice more so since 1980, and amniocentesis first done in 1877 for polyhydramnios, first done for chromosomal study in 1966, and common since 1970. This was usually a second trimester diagnosis, so there was always a search for an early diagnosis, and chorionic villus sampling, because of ultrasound, became popular and greater acceptance since 1980 onwards. Of course, the inverted pyramid and the rapid expansion of serum and ultrasound screening is widespread in use since 1990s to the present times. So it is so very important when you are taking up a patient for an invasive technique to do a good genetic counseling, because like what we discussed, indication for the referral has to be reviewed, because you cannot just do an invasive technique which is not chromosomal dependent, and then you don't know what is the cause of that defect in a discussion. So you have to also discuss the alternate procedures which are available, because the patient may come and tell you that why did you not do this procedure and why did you do the other procedure. And when you are talking about invasive technique, you have to speak about the complications, but believe me, the complications are more spoken of and less encountered, because now the procedure with good ultrasound and ultrasound guided principle and doing the invasive technique, the problem of complications is become less and less. You must tell the patient, if she doesn't agree to do an invasive, risk versus advantages and testing versus no testing. Only when you have done this, you are in a position to say that you have taken an informed written consent. Obstetric history is so very important, because if you know that she has been pregnant so many times and she doesn't have a live child and there were so many abortions, it speaks volumes about something is wrong somewhere. You should also rule out the intrauterine genital and cervical infection. And if there is bleeding in the current pregnancy, or she has been habitual in past also with bleeding, you must keep in mind that these are the patients who are a little higher risk than the other patient for having a pregnancy loss after an invasive technique. Ultrasound plays a very, very important role, and it starts with knowing the fetal viability, whether it is single or multiple pregnancy, and the biometry is so very important, so that you know that she is matching with the dates, or is there some problem. And also, when you're doing an ultrasound, you should look out for subchorionic bleeding. And procedure related, if you're doing a CVS, you should identify chorionic frondosum and amniotic fluid pocket. When you are doing transcervical procedures, the uterocervical relation is very, very important. Overall, ultrasound is very, very important. When you are doing an ultrasound, also keep in mind that you are going to do invasive technique. So you should orient the procedure like as if you are seeing your roadmap on GPS, that this is how you are going to go, and this is how you are going to enter, and this is how you are going to reach the target and take the tissue fluid which is required for genetic diagnosis. So talking about amniocentesis, so this is what you should be able to see it on ultrasound, this image with a good fluid pocket containing amniotic fluid. Earlier, before ultrasound, it was the touch-guided technique. Touch-guided technique was you palpate and you feel and identify and sense that there is fluid, and perpendicular the needle goes at 90 degrees to the entry point and you can tap the fluid. But ultrasound has made it more and more precise. The principles of ultrasound which are followed, what you can see in this slide, you can see that the transducer is held with the non-dominant hand, and the dominant hand has the needle, and you will see that this needle is kept at 45 degrees and it is kept in the center of this thickness of this transducer, because it is that center of the transducer where the ultrasound beam is going to visualize the needle, and then you have to see the entry point, the shaft and the tip of the needle. If you follow the principles of ultrasound, there is no other way but to seeing this needle. And these are the few things which are required. You require a spinal needle, a longer needle in an obese patient. Then you require 2 test tubes with conical tip, and also you should have these tubes with screw lid so that you don't leak the amniotic fluid or the media in which the chorionic villi are suspended. They shouldn't leak off. And of course, you require a package, a box like this for transport. Amniocentesis sounds to be very simple procedure, but at times it may not be without risk. So amnios can become difficult or may encounter significant problem during the procedure. So what are the predictive factor of difficult amnio procedure? If you have the anterior wall fibroid or a low amniotic fluid pocket, and more so in the lower pole, doing an amniocentesis in the lower pole is not without risk, because the gravity when the patient is up and about, the possibility of leaking from that puncture site is there. And then anterior placenta, you have to see that you get a amniotic fluid pocket which is away from the placenta. But if there is no other way, you should choose the thinnest portion of the placenta to enter. Then a maternal obesity can make it difficult. You may require longer needle, manipulation of the needle or maneuvering of the needle may not so be easy. And if there is already a vaginal bleeding, these patients are at high risk. So the difficulties encountered other than that are, when you are oriented very well and you have seen a good pocket, and when you have started to do the procedure, the fetus may move and come to the needle. You don't have to worry about that. You have to hold for a minute, just relax. Maybe the fetus will move away. If not, you may have to pull out the needle because you have hardly done anything. You have done no harm. You can reinsert in a different spot. Difficult needle insertion is possible when there is maternal obesity, and when you start the procedure, if there is a Braxton Hicks contraction, even the uterus, the penetration of the tip of the needle will as if there is a fibroid, and it will be difficult and it will cause pain. So you should wait for a minute or two, let the Braxton Hicks contraction disappear under your ultrasound guidance. You can take the needle ahead further. A very peculiar thing is noted at times. You have a needle, a good new needle, a good quality needle, and when you are pushing the needle in ultrasound guidance, you see that the fluid is not coming, because what really is happening, there is tenting of the membranes happening. You are pushing away the membranes like what you are seeing in this diagram, and it doesn't penetrate to give you amniotic fluid. Now it is seen that such event is associated with fetuses with chromosomal abnormality, and this was noticed commonly in early amniocentesis by Johnson in 1999. A bloody tap, when occurs, is due to its encounter to the sinus in the anterior placenta and may come from vascular injury to the fetus. Problem amnios have bloody tap, but a bloody tap alone does not necessarily mean problem. Number of insertion. This is a frequent question asked, because if you don't get it in 1, 2, how many insertions you can make? The message is every needle insertion raises the risk. Avoid multiple insertion whenever possible. At a given time in a procedure, not more than 2 needle insertions should be done. You must believe that that is not your day that day, and abandon the procedure, explain to the patient, and you can try later. According to March and Dimes, 1 to 2% of women experience cramping, spotting, bleeding, or leakage of amniotic fluid after an amniocentesis. Risk for miscarriage somewhere between 0.5 to 1% after amniocentesis is known. Many a times you get a call from the lab and you are asked to repeat the amniocentesis. This could be because of insufficient fluid, or the fluid is contaminated by blood or with maternal cells. So you may have to repeat and give clear fluid in the second attempt. Also, there is a possibility of a repeat amnio when lab unable to culture enough cells from the amniotic fluid for karyotyping. Now talking about chorionic villus sampling, and this is a beautiful image you should know, and you should be able to differentiate. This is the fetus, this is the cord insertion, and at the cord insertion, what you have, this is chorion frondosum, and it is the chorionic frondosum which have growing, budding, branching villi, and these culture well. If you land up taking a tissue which also looks like chorionic tissue, this is chorionic levi, these are usually the degenerating villi, and the culture may not happen and you may not be able to give a diagnosis. So you should also know the anatomy of the pregnancy and the fetal sac, and you should believe that gestational sac does not fill the uterus. You see there is so much of space over here. Then it is very important to identify chorion frondosum and the decidual border, the chorionic levi, the amniotic membrane, and the extra embryonic space, and this is the yolk sac. So this anatomy speaks a lot and tells you that all is well or there is some problem, and frondosum villi are loosely anchored, budding and mitotically active, and therefore the biopsy should be taken from chorionic frondosum. So there are 2 ways to do this. Transcervical chorionic villus sampling and transabdominal chorionic villus sampling. Who decides the route? Not the operator, because some operator may be good at transcervical and he would want to do every case transcervical, and some operator is only going to do abdominal. No, the location of the chorionic frondosum, the position of the uterus and cervix, presence of uterine or cervical abnormalities, and above all, the operator's expertise, and even above that, it is the patient's cooperation. So what are the devices which are used for a transcervical chorionic villus sampling? This is a stainless steel malleable cannula with an olive tip and gauge 16 and length 20 to 22 centimeters. This is locally been designed in Mumbai by us, and this is called Dr. Sahitya's transcervical cannula for CVS. And these are the needles which are used for transabdominal CVS. Common to the procedure requiring whether transabdominal or transcervical are the 10 cc syringe. Mechanical suction like this may be required if the gestation is about 11 weeks, 12 weeks, because by that time the chorionic frondosome is thicker. Therefore, you may require a mechanical suction, and this happens more often now because we wait until 12 weeks when the dual marker screening is done. Earlier, we used to do chorion biopsy at 10 weeks plus. Otherwise, now we have to wait till the dual marker, and therefore sometimes you may require to do mechanical suction. Then, of course, the transport culture bottle, the Petri dish. This torch is magnificent. When you keep this Petri dish with media in it and keep it on this torch, you can see the villi like silk threads, and you need not require dissecting microscope. In the earlier, when we started doing CVS in the early 90s and late 80s, we used to have a dissecting microscope to identify the villi. So this is illustrated image of the ultrasound guided transcervical chorionic villus sampling, and this is the zoom image of the same. And the procedure in action, ultrasound evaluation just before the procedure is very, very important, because you have to orient. After doing that, you should have an aseptic precaution, and this cannula which I told you, malleable cannula, has to be shaped according to the image what you see on ultrasound. It may be as bent as this, or it could be slightly bent, or it could be straight. Depends upon what you see on the ultrasound image just before the procedure. Then it's ultrasound guidance, and once you are in the chorionic frondosome, negative suction and to and fro movements tangential to the sac. That means you are in the thickness of chorionic frondosome. This happens only when there is good obstetrician or operator ultrasonologist coordination. So this is an illustrative image, and this is how you see it in ultrasound. And you will see this is olive tip of the cannula. If you give a pull with a tenaculum to the cervix, you may even approach the midst of this chorionic frondosome and get good villi. This is illustration of the transabdominal. This is a zoom image, and this is how the procedure is done. Only thing is, here you may require to do back and forth movement because you may find it difficult to be tangential to the sac. So this is the image of a transabdominal chorionic villus sampling. This is the chorionic frondosome. There are some difficulties which you may encounter with transcervical chorionic villus sampling, and these could be due to cervical factor. When you encounter a long stenosed cervix, a pinpoint external os and a stenosed cervix, you may see most of the cannula is taken away by this length, and therefore maneuvering, entry and maneuvering of this cannula may not be so easy and may be difficult. If it so happens, you must switch over and go for transabdominal approach. And if you see on sonography that there are myomas at the point of entry, you will find that the cannula doesn't move ahead. If it is a cochleate uterus, anteverted antiflex, you need to have a bladder or a good pull on the cervix and straighten the uterus like this. Bladder is very, very dynamic in making the procedure the way you want. And then, of course, in transcervical, you should not have erosion, infection, or polyp hanging from the cervix, because you will do a good procedure, but the patient will keep on oozing from here. She will keep on calling you, and you will start wondering what happened and get worried. About the uterine factor, retroverted and fixed uterus, which can happen due to PID or previous surgery, makes the procedure somewhat difficult. But you have to know that you can easily do this procedure by having just an adequate bladder, not too full, which adds fuel to fire, and that you should sonographically guide yourself into chorionic frondosome, and then like an ink pot approach you can get good villi from this area. Deviated uterus is like driving towards chorionic frondosome. You should see that the ultrasound guides you and you are going to go left or right in the deviated uterus like what you are seeing here. Then talking about the chorionic frondosome, you may encounter a location of chorionic frondosome, chorionic previa. You should not encounter this because she will start bleeding in front of you, and it's going to be eventful discussion after that. So such cases are left for a week or two. You should let this chorionic previa migrate, and then you can do a transcervical, or you can take a transabdominal approach. If you see a subchorionic hematoma, you postpone the procedure and you can wait till the healing of this has taken place, or you can do an abdominal careful approach. And sometimes you are not able to differentiate between chorionic frondosome and levi. Although you are seeing the cord insertion, then you must follow the cord insertion and take the villi from there. Now the bladder, the best friend for yours for ultrasound and the procedure. You should not have a very big bladder. If you have a very big bladder, thinking that you are going to visualize better, the uterus and the cervix is going to ascend higher. You may not be able to reach or even see the cervix, and also accordingly, the chorionic frondosome is going to go higher up, and the ultrasonologist will be in difficulty guiding you and cause a lot of pressure pain to the patient who has a full bladder and the pressure on it. The other end is insufficient bladder, poor imaging and guidance is what happens. So adequate bladder, which acts as an acoustic window, is suitable for procedure, guidance and safety. Transabdominal CVS, like if there is a posterior placed chorionic frondosome, anterior wall myoma, obesity, intervening maternal abdominal structure, it may make the procedure difficult, and you have to be very careful and you have to identify all this. Now talking about twin pregnancy, nuchal translucency has really helped us now to identify that there is a problem. Sometimes there could be problem only in one fetus. So we have to do a specific counseling and use separate sets of devices. You may require a different route. One, like what you see, may require a transabdominal approach. The other may be possible transcervical. But you should know this dividing line, and you have to limit the passage of cannula and its tip, and see that you limit in each chorionic frondosome and not be overzealous and go and try to get material this way. You have to have from A sac, you have to have from B sac separately. You must explain to the patient about the diagnostic error, and you should have mapped all this, because this patient may require selective termination. Also, you have to counsel for vanishing twins. Otherwise, the procedure will be blamed if one of the twin vanishes. Now, there was a big hoo-ha about the Cvs and limb abnormalities. This was in the very early stage when CVS was done even prior to 8.6 weeks gestation. So now what one has to know that guidelines are that you should never do a chorionic villus sampling before 10 weeks of pregnancy. And why? Because when you take out tissue in a very young pregnancy like that, it's going to lead to vascular insult and incomplete morphogenesis, and it disrupts the normal embryogenesis. Therefore, the limb abnormalities was blamed when early CVSs were done. So when you are done a CVS successfully, what you should see in your Petri dish, you should see distinctive frond-like appearance villi, bud-like projection, and the blood vessels coursing along the surface. The quantity should be about 15 to 20 milligrams when it is weighed when wet, but it's not necessary. If you see one bunch like this with so many villi, I can give you all the diagnosis. So this is the histological appearance of a villi, and it tells you about the cytotrophoblast, the syncytiotrophoblast, and the mesenchymal core. Why this is important? Because villi tissue, after being subjected to trypsin, the mesenchymal core is for villi culture. So this is what is used, and it gives you a culture. But the cells, the cytotrophoblast suspension, gives you a direct preparation, and you can do your fish and all with that. Chordosynthesis only required when CVS and amnio are unconclusive, and a good sonographic imaging, seeing the cord insertion. It could be transplacental approach, it could be transamniotic approach, and the fetal loss risk is variable depending on the operator, because there is not much experience in practice in current times about chordosynthesis, and overall it could be 6%, ranging from 1% to 50% depending on the hands behind the procedure. Bradycardia is common but transient. Bleeding is transient. You may see a spray on ultrasound. The site of puncture is bleeding, but it can seal off very fast. Now, training for invasive procedure should begin now on Mannequin and Simulator to practice maintenance of the needle path within the ultrasound window so that the entire needle remains visible at all times. So these are the Mannequin. This is the Mannequin, and it's a dual Mannequin. If you use this simulator in this, you can do transabdominal training, and if you use this simulator in this, you can do a transcervical procedure. So this is the transabdominal procedure, and this is how you will see on ultrasound using this simulator Mannequin, and you can practice transabdominal invasive techniques. And this is how you will see the transcervical when you use this simulator, and the cervix is visible here, and you can do a transcervical training. So these are the two Mannequins. This is the Mannequin, and these are the simulators. This is transabdominal. This is for transcervical. And this is how the students of ICOG So these simulators make you feel as if you are working on a patient. So clinical training after you have done on Mannequin, I think I've seen people just waiting to get back to their clinic and wanting to do the procedure because they realize it is so very simple. So clinical training will begin after that, and you should start under supervision of an expert. Simple amniocentesis like placenta posterior with adequate amniotic fluid, an easy accessible chorionic tissue at the anterior wall or the posterior wall, easily accessible either by transcervical or transabdominal. And you can practice this in women undergoing termination of pregnancy and taking an ultrasound machine to the OT, and you can also practice there, but with due permission from the patient. The minimum number of procedures that is necessary for an operator to perform in order to optimize their competence is in doing safely the procedure is about 45 to 300 procedures, and that is what is required, and it should be with under the supervision of an expert. So this is how we conducted the first ever training on simulator mannequin at the CMAST Mumbai, and thereafter we have done so many workshops in all the cities across India, and we carry this mannequin and we train. This is in Bangalore, this is in Pune, and we have a short weekend course also where all this is done at Pushpa Hospital under my care. So I will show you some videos now of the procedures, and you will see how the principle is followed. When you see a procedure, you should try to follow the principle that it is coming at 45 degrees of the transducer and it is going into the pocket, and you see the tip of the needle. When you do that, you are not going to make a mistake. See the needle coming at 45 degrees and the fluid is here, and you are going to very safely get as much as fluid you want. Usually it is about 15 ml for 15 weeks and 20 ml for 19-20 weeks. And this is the transcervical CVS under ultrasound guidance. You are just under the beam of the ultrasound, and this is chorionic frondosum. You should be little more in the center here to get, and this is the live case of a CVS. And just before the procedure, you have to evaluate. You have to see the bladder sufficiently giving an acoustic window. You have to see the cervix. Your cervix is so very scarred and it is going round like this, but never mind. If you have a good ultrasound guidance, you can negotiate this, and this is the chorionic frondosum. So you will see next now the cannula coming in, and before that you will do aseptic precautions, just like any minor procedure of gynecology. You have to preform the cannula. You have done an ultrasound and you have located the chorionic frondosum. So next is you have to preform the cannula, and the curvature will depend upon your image what you saw on ultrasound. Negotiate. There, it's so simple. Ultrasound has made life so simple, and you are able to fill up the syringe with the lab provided medium. Chorionic frondosum, tangential to the sac. So simple is transcervical chorionic villus sampling in the hands of a gynecologist. Because we are so accustomed to do internal procedures, the copper T, the IUI. So who can do it better than a gynecologist? So these are the villi, what you see. So you have to pick up these good villi, aspirate in the same syringe, and feed it to the conical tip tube containing the lab provided media. And then do one scan post procedure, show it to the patient, the cardiac pulsation, and see whether there is any hematoma from the site, and rarely you will find anything like that. This is transabdominal CVS, again 45 degrees, ultrasound guided in the chorionic frondosum. This is another chorionic transabdominal chorionic villus sampling. So it's coming at 45 degrees, ultrasound guided in the chorionic frondosome, and you take a good biopsy. Now, this is an easy procedure made difficult by lack of coordination, ultrasono and operator coordination. So the needle is lost. You should not move the needle after it is lost. You must take a deep breath, hold, relocate the needle. Don't see these artifacts and thinking that these are the tip of the needle. And this is photosynthesis. This is placenta. This is cord insertion. And again, you will see at 45 degrees the needle coming through. Yeah, entry point is coming there and going there, and with a jab, you are going to get into the umbilical vein. There you are. And you can have a good tap of the fetal blood and send it for diagnosis. So take home message, my friends, scan just before you start the procedure, identify the target, recognize the intervening structures, procedure orientation, and you must plan the entry point. The distance should be away or close depending upon the depth of your target, and the angle of should be always 45 degrees. Remember, do not advance the needle blindly. Needle tip must be identified before push. Do not swing, jiggle the needle to identify the tip. Keep the probe steady during needle movement. So in conclusion, amniocentesis and CVS are safe and used to diagnose a multitude of abnormalities through karyotype, analysis and molecular study. CVS allows early diagnosis, but both procedures can provide highly accurate results in the first half of pregnancy. Photosynthesis, fewer indication that allows direct laboratory testing of the fetal blood. Ultrasonography has expanded the capabilities of perinatologists to examine, test, and treat the fetus. These are the mannequins you already saw. This is the transcervical cannula, which is economical, reusable, easy autoclavable, malleable to all shape, olive tip for good imaging. This is literature. I think this is the only literature there available which gives you all the principles of ultrasound guided invasive techniques. And this is one, Indian Society for Prenatal Diagnosis. This is compilation of all Indian experts practicing principles and practice of fetal medicine. And with this, I thank you for giving me an extended hearing, because I was very keen to express that invasive prenatal diagnostic technique, don't shy away from, learn them and do it for your patient when required. Thank you very much. I hope everybody's...
Thank you. Thank you, Raju sir, for that wonderful talk. Of course, as usual, we thoroughly enjoyed listening to you, listening to the wonderful teaching points that you have just put forward to everyone. So can I kindly request Dr. Farooq Zaman sir, I see him here. Sir, can I kindly, Dr. Firoza Begum ma'am, can I kindly request you to give the concluding remarks for the talk, please?
Yes, thank you very much, Dr. Raju, for a very illuminating and illustrated presentation. It was worth the wait, and you did the right thing in giving your talk in detail, because it's so educational for everyone. And it is also motivational. The way you have conducted workshops all over India and trained so many people. And that's why so much of advancement in assessment of the fetal abnormalities, which help so many women and couples and families, as a matter of fact. So hats off to you. I feel myself lucky to be part of this panel and having attended this workshop. I am myself motivated, although rather late in the day for my career, but it was very illuminating. Thank you very much.
Thank you, and it's never late. You can do it even now.
Yeah.
Thank you, sir. Thank you, Dr. Farooq Zaman, sir, for concluding the talk, and Dr. Raju Saikia, sir, for the wonderful talk and the wonderful videos that you just put forward for the teaching lessons of everyone. Thank you so much, sir, for that. So we have come to this end of this wonderful session. 3 excellent talks and 1 excellent panel discussion with a lot of take-home messages. So we have with us Dr. Yusuf Latif Khan, who is the Secretary General of the SAFA. Can I kindly request her to kindly deliver the vote of thanks? Okay, I don't see Yusuf Latif sir here. Rohana sir, you're with us. So can I request you to kindly deliver the official vote of thanks?
Okay. Thank you, Priyanka, for giving me the opportunity. I think everyone will agree with me that it was a very wonderful, educative, informative webinar. Though we took a little bit more time, but it was worth waiting and listening to all these lectures and delivered by Dr. Manjeet, Dr. Anna, and Dr. Raju also. Actually, we would have lost the real opportunity of listening to you, which really made all of us understand that these invasive procedures are not so difficult. And I think because of your expertise, it was made so easy. I think now people will reconsider these facilities. So thank you very much. And then, of course, we had this excellent panel discussion, which was really informative with the participation of so many experts in this field, Dr. Firoza, Professor Farooq Saman, is our past president of SAFOG, who has been very, very helpful in all the programs and guiding us in SAFOG activities. And then there was Dr. Atula, Professor Yusuf, all contributing with their experiences and expertise and related to the SAFOG countries, because we have limitations in our resources. So taking them into account, so we were able to discuss it in very well, and it was very informative and very helpful. And I think Dr. Narendra and maybe Dr. Firoza will come out with the protocol of this pre-invasive diagnosis and screening, and also we had Dr. Atula as well, sorry. And this protocol, I think in the SAFOG, I think we have to go through an expert committee and then finalize it, and then we should be able to agree on a protocol which is practical and which could be adopted by our SAFOG countries. And then that was anyhow, without taking any more time, I also would like to thank the 2 moderators, Dr. Nirana and Dr. Priyanka Roy, who did an excellent job in moderating this sessions very well, so that we were able to enjoy the session. So thank you very much again to everybody who participated and all the participants who joined this program. So thank you. We'll see you once again in the next webinar. Thank you very much.
Thank you, Dr. Rohana. Thank you for the kind words. Thank you.
That we come to the end of this wonderful session, wonderful SAFOG, IAPM, and Iron Donor International Academic Exchange webinar. Thank all the speakers, the chairpersons, the moderators, the panelists, and everyone who were there with us. So thank you so much once again. Stay tuned for the next webinar. Take care of yourself. looking forward to seeing all of you physically at some point of time, and of course virtually in the next webinar. Thank you so much. Bye bye. Good night, and have a good day. Thank you so much.
Thank you. Thank you.
Thank
Good
you,
night. Good
everybody.
night.